So we hope that technique is working. So thank you very much for being here to listen to the highlights from the advanced prostate cancer. After we heard about the future, now we're going really back into daily clinical practice. And this is what the APCCC is about. So it's not about fancy new tests. It's really or treatments. It's more about, you know, what are you doing with your patients that you see every day in your clinic, and where we don't have good evidence what to do. And I think we all see them every time we have a tumor board or we go into the clinics. Here's our conflicts of interest. Oh my God, mine is much longer than the one from Aurelius. Feel really bad. And here, oh, Elena, nothing, very nice. So you see here the conflicts of interest. So you would be the only one. And here is a bit the question, why are we doing this consensus conference? And we started really a long time ago, 2013, I think we started thinking about it, because we worked in St. Gallen. And in St. Gallen, there was this consensus conference about breast cancer. That's now in Vienna, because St. Gallen was too small to do it in St. Gallen, so they changed to Vienna, so we have again a good reason to be in Vienna.
So we take offers from Vienna, no?
Yeah, so if there is someone from the politicians here from Vienna, so they can, we take offers to make it also in Vienna, because it's a really nice city. And the idea is really then we said, you know, so why only doing it for breast cancer? Because also in prostate cancer, we have several topics where there is no evidence, or sparse or low-level evidence, sometimes conflicting as evidence. And what we saw more and more is also different interpretation of evidence. Sometimes the interpretation is different from the transatlantics, right? So as soon as you're going to the States, sometimes really they interpret data very differently from us. And Elena has shown that very elegantly for the PARP inhibitors. And then, as we all know, evidence is generated only in a selected population mostly, so very selected patients. And what we want to say is it should not be like a competition with the guidelines, because the guidelines are based on good evidence. It's really more like complementary to the guidelines. And this was our idea when we started. This really fancy deal has been done by Aurelius, much nicer than what we had before. So the idea is really that people who can treat or have the luxury to treat only one cancer, or maybe one group of cancers like GU cancers, can give their experience to doctors all over the world that have to treat a lot of cancers, like have a very broad kind of patients. And we really hope that this is working. And here the third aim is actually that we identify gaps of knowledge. Because sometimes we see, and you will see that as well afterwards in the answer, really even the experts have no consensus whatsoever to do in a certain situation. So I think that Ursula wrote me, she's writing on the new GAPS paper from the 2024 findings, so you will see that very soon. So that was our 8 chapters of interests. You can read it, I'm not going into it. We had more than 180 questions developed. We always say, oh, next time we need to do less. But then, unfortunately, because like we are talking a lot with Bertrand and Thomas and everyone, then it's always turning out to be more in the end. And we started to do the voting prior to the conference because of COVID, because we couldn't have a big conference. But we really decided it was working out so well, and people like our panelists have more time to think about the question, that we left it. And this was our panel for 2024, so you probably see some of your colleagues. We tried to be quite inclusive, so really having people from all over the world. So some people say maybe we have a bit too many people from the US, but I have to say, and I don't say that only for Petros, I mean, there are excellent researchers there. But you see, if you have some good ideas who we could include from your country, and we haven't the country on here, let us know. And in October, so months ago, the publication came out. So we worked quite a lot on this publication, and we had a lot of good input from all the panelists. And you see, it's really a lot of them. It's open access. So we paid a lot to European Urology for that. So please take the opportunity and go on it when you have a question in your clinical. No, it's quite amazingly expensive. So go there. Everyone can access, because we really wanted that everyone has access and doesn't have to pay for it. And you have also all the questions and all the slides with the voting results, including the background discussion, but you can take the slides from the supplementary and use it for your presentations. So please do that, so we can spread the word. And now we go and start and really discuss some of the questions and the results and what you think about the results. I give to Aurelius.
Just the presenter, yes. We would like to start with one question on high-risk localized prostate cancer. We also included audience vote, but we realized that we have the results already here, so you may be biased, but let's test it anyway. And these questions always apply to the majority of patients without contraindications and assuming that everything was available, every treatment, every diagnostic test. And we will see the audience vote in a second. For the majority of patients with high-risk localized, locally advanced prostate cancer that meet the STAMPEDE definition, Gleason 8 to 10, PSA more than 40 or more than T3 disease, and you had to have 2 out of 3 criteria. But now the twist is that they had next-generation imaging, and next-generation imaging means PSMA PET, and they are N0, M0 on next-generation imaging. And we asked what is the recommended treatment, and let's get a feel what the audience votes and then compare it to the APCCC votes. It's radiation plus long-term ADT, radiation long-term ADT plus ABI for 2 years based on the STAMPEDE data, radiation long-term ADT and docetaxel. You throw in chemotherapy. We had arguments yesterday that in bulky disease that might be an option. Or you can vote, and I know that the audience, there's a lot of urologists here, you can vote for surgery. Recognizing, as we said in the answer options, that it may be the first part of a multimodality approach. Okay, interesting. So clearly more surgery here, almost a third, 26%, 61 go for the STAMPEDE-like approach with radiation, long-term ADT and ABI for 2 years. Some would only vote for radiation and long-term ADT, 2 to 3 years. No one voted for docetaxel. Let's go back to the APCCC slide. I think that is very well reflected here, almost identical proportions. Bertrand, as a urologist on the podium,
that's
you need to the microphone.
No, that's crazy because there's absolutely no trial showing that surgery increase overall survival in that population of patients. So once again, it's the argument, yeah, we're gonna delay radiotherapy and hormone therapy. If you plot a high-risk STAMPEDE patient into the mHSPC nomogram, it is 99% PSA progression at 5 years. So the question nowadays is not should we operate this patient, but what would be the added value of putting surgery in the care pathways? So first. Second thing, it is the amplitude of the benefit of adding abiraterone. You know, I might be biased, I've been in the IDMC of STAMPEDE, but the failure-free survival is 85% at 7 years. So, I mean, well, how do you justify surgery in these patients? That's really what you tell them. What promise do you make them? Because, you know, I'm very sorry, but it starts to be slowly unethical to offer surgery to these patients. I'm sorry to be provocative, but at some point we have to realize that. What do you tell them? What promise make you to these patients with surgery?
I guess this was also reflected by the EAU guidelines, right? Where the statement for surgery in this situation is only now weak recommendation and a strong recommendation for radiation combined.
But can I be provocative? And I'm not a urologist, but you know, this is N0, M0 on next generation imaging. So I think, you know, a lot of the patients who went into Stampede had, I mean, of course, all of them had only conventional imaging, and probably a lot of them in PSMA PET would have had either N1 or even M1. So you have here selected 4 population. That's probably the better population from Stampede. So maybe some of the urologists in here or some other people would argue like that. I don't know.
But there are those who benefit the most from the addition of AB. So we know, it's been shown by the Japanese 15 years ago that maximal androgen blockade do benefit stage C disease, and simply adding bicalutamide, AT at a hazard ratio of 0.62. This is the famous ACASA trial. I see my friend from South Korea here saying, yes, that is the standard of care for this patient.
But Bertrand, from a patient's perspective, and I come from a site where the urology is very strong, they like to operate, especially in these patients. How do you sell in surgery, even if you say it's a multimodality approach, compared to radiation and ADT for 3 years and ABI for 2 years?
Yeah, but what do you mean by multimodality? To me, don't take me wrong. Surgery is a great treatment, but here it's not surgery. It's surgery, and within weeks or months, radiotherapy plus salvage treatment. And radiotherapy plus salvage treatment, there was a very nice presentation by Peter Oskin yesterday. The crude benefit of adding 2 years of hormone therapy is 5% in MFS. Here you have close to 20% in MFS. So come on, that's I don't know how people read. I can't say, oh, you can sell this to the patient.
But there are trials ongoing.
I would say that anything
RPs,
you would tell
right?
them
Also
is a
for
lie.
surgery.
Yeah.
So I think this is maybe the good news. There are now trials ongoing also with RPs for high-risk patients and surgery. So we'll see the results. Fabio, sorry.
I have a practical question about this question. So what do you mean for long-term ADT in this term? So 3 years of ADT like in the Stampede trial, or only 2 years? I don't know what to recommend with patient when we start to talk about this, the duration of ADT.
Stampede is 3 years ADT and 2 years AB, so that's because the SOC was 3 years of, but it's 3 years ADT, 2 years AB. So it's because the comparative arm was 3 years ADT, but I mean, most patients we would do 2 and 2 and not 3 and 2.
I fully agree. So this the standard. Sometimes we are reducing just to 2 years. Nevertheless, coming back to the multimodal strategy. So I think what we are losing in this concept is the addition of ABI, because we don't have any evidence to add ABI in addition to ADT in the post-op setting. So I think it is an important message, because when we are treating this patient, combining radical prostatectomy plus adjuvant radiotherapy, and we don't know which is the duration of ADT even in this setting, because we can do nothing, 6 months or 24, but we don't have any strong evidence, but we are losing the benefit, the added benefit of abiraterone. So I think this is an important message.
A lot of oncologists and very few urologists on the stage. So, well, yeah, I saw that, Silke, like that. No, but just a comment. And I'm a bit surprised that Bertrand says that we have the evidence for this, because that was the point of this question, is the APCCC, is that we don't have the evidence, and we don't for this new next generation imaging. And I would say that we do not know this. And that was the first thing, and I agree with you, Silke. We don't know this. And the second one, but the second point that I like to make is that I agree that it would be multimodal. I agree that it's a big risk that this man will have to have hormone therapy for the rest of his life. But that would be the same thing after radiotherapy, that after these 3 years, there's a fairly high chance that this man sometime in the future also will need to get his hormone therapy back. I mean, I agree that you cure quite a lot of them, but there's also, after these 3 years, a PSA relapse, and that would also be sort of bimodal at least, therapy that we're not talking about. We do all the models from the start with the radiotherapy while you do it sequentially after surgery in a different way.
Unfortunately, your argument is unacceptable because what you are doing is a basic methodological error, is that you are attributing a prognostic value to a test when it has not been done. So today, you have once again no data at all to say that Stampede N0, M0 do better than Stampede N1. No argument. Caroline is there, but to me, the prognostic value of PET PSMA has not been fully demonstrated. So the only methodology you can do is the intent to treat analysis and say, in the intent to treat analysis, AB increase overall survival by a massive hazard ratio. So you can't, it's very dangerous for the patient to infer a prognostic value to a test, unless I haven't seen the recent data, but based on what are you telling me that these patients have a best prognostic?
But you're still extrapolating data from the conventional imaging to the next generation imaging, and that is your thought in. No. You are, when you're saying that this is wrong, the 22% that says this, we do not have the data for the new generation imaging, and that was my point. And
yeah, that's why we did the question. But Johan, just to tell you, if you add the abiraterone in the Stampede trial, even if they are poorer prognosis than these patients, because they are mixed, right? They have probably some patients who have N1 and MC, like we think at least, it's quite likely. Yeah. The progression-free survival and the overall survival is fantastic.
Oh yeah, I agree.
So and what Thomas is saying, in your multimodality, you don't have the data that right now that you could add the RP there. That's probably very important. Yep. So the data is going to come, but I think for the moment, if we want to give an RP, if we think the RP is important, and I think all of us think that the RP is very important in that situation, we need to go with the radiotherapy because there we have the data.
We have 1,050 patients randomized in the SPCD15 trial out of the 1,200 that we need, and that is for this. It is not with the next generation imaging, but we will find some of it in the future.
No, that's fantastic, and that's why it's so great that these trials now are be done, right? And maybe if I just as last thing say that in Stampede, quite some of the patients didn't die from prostate cancer. They died from heart disease. So maybe in some of the patients, you don't want to give all 3 years. I guess, Thomas, you would agree, right? So yes, the study was with 3 years, but if you have patients who you think, they're very fragile, like heart-wise, maybe you could rethink that. Of course, we used the 3 years because it was in the trial since the beginning. But I think we have to be a bit more granular with our patients.
And of course, in the 60 pages of the manuscript of APCCC, we have included that question. Can you reduce the duration of ADT because can you stop everything after 2 years? But maybe the next question, and I don't want to have an audience vote on this one because time is running fast, but maybe this is the solution, no? In patients with high-risk localized, locally advanced prostate cancer, plan for radical prostatectomy, maybe as part of a multimodality approach. Do you recommend, and again, this is something I see quite frequently at the MDT, that the urologists say, can't you give combined systemic neoadjuvant treatment before surgery? And I think here we have a consensus, which is defined as 75% or more against a neoadjuvant treatment, even if it's a combined ADT plus RP. Bertrand, you're the urologist again on the podium.
No, the same. Rudolf Giuliani, only got, I believe, for the rest show me the data. So there's no data. There is a nice trial going on. There's a beautiful trial in Leuven that basically showed that the rate of complete response is no less than 30%. So technically, it's not working on the local. And we're going to have to wait for the Proteus trial. I guess it's going to be 2025 also, we all hope, to see what apalutamide does. So Proteus will answer that question.
And we will have questions for 26 for APCCC on that, provided that we have the trial results. The next question is about lymphadenectomy, and then we leave the field of high-risk locally and locally advanced prostate cancer. Again, in the majority of patients for whom a radical prostatectomy is planned and who have now a negative PSMA PET as staging, N0, M0, do you recommend an extended pelvic lymphadenectomy? If they are, now we used to be a bit more granular, as Silke likes to say, the NCCN criteria of unfavorable intermediate risk localized prostate cancer. You see it's a very mixed pattern. Then we go to high risk NCCN definition, localized prostate cancer, and to very high risk, which NCCN has included. And the green part in the majority of patients increases significantly. It never reaches a consensus. And the blue part, if we add that in selected patients, yes, it would meet the 75%. Can we get again a surgical vote on that question? We are still awaiting trial.
I don't know if you're following Declan Murphy on X, but there was a fierce debate between Declan and Andrew Vickers on the interpretation to be given to the US trial that showed no benefit in PSA. I think Johan showed it during his presentation. So the answer is after 25 years, we still don't know. How
do you do it in your practice?
We don't do surgery on very high risk, and in high risk, we don't necessarily believe the PET PSMA, because we know there's going to be more lymph node. In any case, there are many trials on this, so we still do extended lymph node dissection in unfavorable and high risk, and we don't do surgery in very high risk anymore.
Okay, I guess that's very clear. I think there are some countries where it's not done, and there are some countries where it's where people believe very much in it. I think in England, from what I know, I don't know, Rob or maybe if you can tell us, I had the impression that lymphadenectomy is not part of, right? Of the
probably also not a financial incentive, which in some countries it is, because the surgery is more complex and you can charge more.
No,
I not only nuclear medicine, but also surgeon.
Also surgeon now.
Yeah, I'm also a surgeon now. I've always said that surgery for prostate cancer improves quality of life for the surgeon. Yeah, no, sorry, I didn't say that. No, but I think extended lymphadenectomy is quite a challenge, actually, and my hat's off to the surgeons who do it. I went to the theater to watch it, and it is not child's play at all. And so people who vote for extended lymphadenectomy, I'm not sure how many of them are actually doing extended lymphadenectomy, or are they cherry-picking the lymph nodes? And that's what causes an issue. Silke, I've had one question. This is great. But what I wanted to know is, I saw in two questions, in one there was abstain or unqualified to vote 0, and in another question, there were 6, and they were pretty similar questions. So people felt that they can answer a question about radiotherapy and abiraterone and the duration of hormone therapy, but they could not answer a question regarding use of systemic therapy in surgery. I just find that a bit odd, that who's abstaining at what time point, because we are giving a lot of credence to these outcomes. And there may be reason to try and take out those abstaining ones to be uniform in a way.
Yeah, it's difficult, but it's a very good point, right? So if it's only, it's 120 panelists, so I mean, if it's 2 or 6, probably doesn't make such a big difference. But we had also really questions where a lot of people didn't find themselves qualified to answer. I have to say, I'm happy if people say that. This is not so easy to say, right? Oh, I'm probably not qualified to answer that question. But it could also be that you want to abstain. We have it in the definitions if you have a conflict of interest. So if you feel I was part of Stampede, you don't want to vote on the question, you would be also in that abstain or unqualified to answer. So in the end, I have to say for our votings, I'm happy that some people are honest enough to say I'm not qualified, to say how much radiation I have to give, because I really, personally, I leave that to Thomas every day. So why would it, I think I'm going to answer that in the APCCC. So this is how we did it, but of course it's not 100% perfect. You're absolutely right. So now we go to CN1. I think this is also a question that comes up a lot. So now you have these, little lymph node that may been seen in the PSMA PET, and you don't really know what to do with them. And this was the question. So you have CN0 on conventional imaging, but you have a clear positive pelvic lymph nodes on the PSMA PET. No distant lesions, neither in conventional nor in novel imaging. But it's otherwise not meeting the STAMPEDE high-risk criteria. So we asked also here what to do, and you see here still 71% would add the abiraterone because they believe in the PSMA PET, even if these patients clearly were not in the STAMPEDE trial. So because they didn't meet the other high-risk criteria for STAMPEDE. So I think, we all believe in that kind of triplet. Maybe I let Thomas comment on that.
Yeah, I think it's an important findings. So I think we would believe in RP. In addition to RP, we don't have any clear evidence because finally this patient could be just treated with long-term ADT, and the majority of the data that we have are based on long-term ADT. I think probably with the new trial that are ongoing, there is a French trial looking specifically at this patient with N1 disease on PSMA PET-CT. We'll probably have more ideas of which is the best treatment, or if we are just over-treating these patients.
Yeah, exactly. It's exactly the same. People are attributing a prognostic value to a test, and it's not been done. In that population, the most important thing that will decide whether ATLAS, DIALIS-CAP, and NZARAT are positive is the relative proportion of death from prostate cancer and something else, which is going to be captured by MFS. This is why MFS is a surrogate to OS. And in STAMPEDE, many of patients die from prostate cancer. Once you get a STAMPEDE patient, and here it's not a STAMPEDE patient. So you make, it's public, everybody know it, that the relative proportion of death is ATLAS and NZARAT. It's not even 50-50. 60% of the patient, they die from something else. So if you're adding abiraterone to these patients, what you're going to do is increase the proportion of patients who are going to die from another cause. And in the end, there is one true, you have to die from something else. So here, it's exactly the same comment I made about the surgery, is that here we are extrapolating on the prognostic value of a positive PET PSMA. Keep in mind, it is N0. So by definition, we are speaking about lymph nodes that are less than 15 millimeters, who have a weak SUV. Come on, the sanction for that patient is huge. So we have to be correct. If there's no data for the surgeon, there's no data for the radiation oncologist as well. Everybody should treat the data the same way.
Yeah, so we said clear, it's a clear positive lymph node, so the SUV should not be only a little bit, but where's our nuclear medicine person? So I guess, this is also something we have to learn. What is PSMA, SUV meaning, and so on. I think there is a lot that we don't know yet, at least me as a medical oncologist, sometimes really difficult to interpret these PSMA PETs. I don't know how you feel if it's not like super clear, super 40, right? So is it something or isn't it? So I think we need really our nuclear medicine colleagues to help us there. So now we speak about PSA persistence. I think also a very difficult question, or biochemical relapse. So now here was the question. So we combined some questions. What do you recommend for a patient with PSA persistence, post-radical prostatectomy, PN0, unextended PLND, and a negative postoperative PSMA PET? So postoperative, already done a PSMA PET. And here again, we asked the questions in different situations. So when the PSA is 0.2 and patient has no risk factors, and the risk factors you see here is R1, PT3, or ESUP grade group 4 to 5. And you see half would go for monitoring or doing an immediate radiotherapy or a systemic therapy or both. if you go to a PSA that's higher, 0.7, we used 0.7 as a cutoff, you see clear, there was a clear consensus for going for immediate therapy, what makes probably sense. And then if we have no PSA, but we have 2 or more risk factors, again, a clear consensus to do immediate therapy and not to wait for a salvage therapy when the PSA rises again. So I don't know who wants, Elena, do you want to comment on the options? What do you think?
Well, I'm not sure if I'm the
I just wanted to avoid that Bertrand is talking against the urologists. So.
Well, I think I'm more or less aligned with what was voted here, that for patients that have 2 or more several risk factors, monitoring and waiting perhaps is not the best option, and just offer them treatment. Then for the others with the slowly rising PSA, we know that it's something that we need to discuss with the patient and offer them, but in some patients, if the PSA is going up slowly, perhaps we don't have to rush. And 0.7 no risk factors, this is something we are going to have to do, but once again, but for patients with risk factors, I think I will offer radiotherapy immediately.
And Thomas, maybe?
Yeah. So I think it seems reasonable. So we know that this patient with persistent PSA have poor prognosis. So I think we need, when we are high PSA, several risk factors also. I think it's reasonable to give an opportunity to a salvage treatment. Probably when we don't have these risk factors, so the PSA is quite stable, 0.1, 0.2, probably we can just monitor this patient for sometimes in case of rising PSA, we can propose salvage therapy. So it seems reasonable as a proposal.
Petros.
Question on that topic. So on the first group, right, with no risk factors, there is the argument from radiation oncologists that the earlier you intervene, the higher the chance to potentially cure that patient. So it seems to be a split there, but could you talk more about that scenario of better outcomes with salvage radiation in lower PSA?
Yeah,
Thank you.
We have this data in the pure salvage setting. There's less well-defined in the persistent PSA. So I think sometimes we have this PSA that are persistent but are quite stable. So I think we can just monitor these patients. Otherwise, when we have a quite huge PSA, so it means that we have some persistent disease and these patients have really bad prognosis. So I think we need to intensify adding radiotherapy, systemic therapy, for how long and which kind of systemic therapy. We don't have any clear evidence on that.
Just to provoke Bertrand again. The thing is, we have data, but also without PSMA PET. So, but this patient, we don't see anything. So we see a PSA that may be 0.7, but we don't see disease on the PSMA PET, right? So what are we treating? And that could be the question, no? For sometimes if we don't see absolutely anything.
Remnant prostatic tissue? Bertrand, is that something that occurs?
Or Johan, do you leave it in sometimes?
No.
I
agree with. I would wait for the first one, and I would argue with that because, of course, you will get better results from salvage if you don't need it. I mean, we don't know if this guy needs it, and that's the problem with looking at nomograms. That if you don't need the treatment, you're going to get 100% failure-free survival, and the first one is we don't know if he needs it. So I would definitely argue for that part and that one.
I would agree with Johan, so we don't disagree all the time. Actually, the first one, we see that quite often. We look at this 10 years ago with Bordet and ULB, and you have a third group of patients, you don't know for any reason, they have a PSA which is 0.2 point surgery, and then you follow it, nothing happened. So 0.7 and 2 risk factor, come on, we tend to forget that in the 3 adjuvant trial, there was an increase in overall survival for patients with, okay, if you go for surgery, at least go for multimodal treatment. So that's okay, it's not your fault, it fails. The guy, he has a negative margin, he's got a PT3 high A subgrade, a PSA at 0.7, and multiple risk factor. I'm surprised by the option 1, where actually I fully agree that the first one, I mean, I'm surprised with the option 2. Because you don't know, like you say, where's the problem?
So it seems for once we all agree, at least here in the room. It's really nice. So if you have only 0.1 or 0.2, you can probably wait because the PSMA was negative. In the other ones, maybe think about treating earlier. So this was really complete. I give that to you.
This also shows that maybe if we have too many options, we can't reach a consensus at all. So this is now, Thomas, I was going to ask you, what do you do in PSA persistence? And if the patient has 2 or more risk factors, as we just discussed, a negative PET, but you decide to go for treatment. Do you do, and there's all the options, just the prostate bed plus the pelvis, so either or with short-term or long-term ADT, or just systemic therapy alone?
I'm trying to propose a comprehensive irradiation of the prostate bed, including the pelvic regions.
Even after extended pelvic lymph node dissections, 30 nodes removed, none of them are positive. We have that discussion, we don't know.
Yeah, so it should be discussed, but probably yes, even with extensive nodal irradiation. So then it depends. If you have just a NER1 disease, probably we can stay just on the prostate bed. But based on the R2G0534 trial, so I probably would like to recommend a short-term ADT plus radiotherapy to the prostate bed and the pelvic nodes. Discussing with the patient that we have a quite high risk of lymphedema following the treatments. For longer duration, so it could be, I'm personally proposing when we have PN1 disease. Otherwise, I will stay mostly on 6 months, but it's my personal view.
We have, of course, all these questions on PN1 and 1 to 2, 3 or more lymph nodes. We are only at question 35 of 180, so we will get there. No, we left it out. But yes, I think, could you also argue to just go for the prostate bed with short-term ADT and leave the pelvis if there's a relapse later?
That could be done. So we have data on the salvage of nodal recurrences, so treating the elective nodal irradiation, so that could be an option as well. So just to be discussed, but certainly if the lymphadenectomy was really extensive, they remove a lot of nodes, probably it should be discussed because we have a quite high risk of developing some lymphedema, and that's a quite huge morbidity for the patient, certainly.
And I guess one thing was clear, systemic therapy alone is out in that situation. So at least I think, it was a lot of non-consensus, but at least no one really voted for systemic therapy alone.
Right. I think we leave these questions out, and we wanted to go to mHSPC. Not terminology. Okay, we go to the triplet question. And I think we have also an audience vote here. To get everyone involved for the last 5 minutes that we have. If you use triplet therapy, ADT plus docetaxel plus an RP, only in selected patients, what is in your practice the most important factor for the decision to use the triplet therapy? We can go to the audience vote. Is it synchronous versus metachronous disease, regardless of the volume? Is it the age, the biological age? Is it high volume versus low volume? And in this question, we didn't specify which imaging method you use, whether it's conventional imaging or next generation imaging. Or people could also vote to abstain if they don't voted for the previous question to use triplet therapy in selected patients. So the volume is very clear by APCCC standards. It would be a consensus and it's going up. Let's go back to the question because we didn't reach a complete consensus, but a majority voted for high volume versus low volume disease. The rest is a bit split. Even some experts voted for age as an important factor to use chemotherapy, yes or no, in this situation. Yeah. Maybe Elena?
I agree. So to me, I think volume is the most relevant one. But age, if patients are fragile, as we saw yesterday, more than elderly, I may not use it. And the other way around. In very young patients, even if they don't fulfill the criteria of high volume, they are in the limit with the low volume. Patients in their 40s with a novel metastatic disease, I often discuss triplet therapy with them because I know they have worse outcomes, and sometimes they are low volume, but they have bulky nodal disease, and sometimes I am more inclined to use triplets in young patients.
If we had a hypothetical additional answer to use Decipher based on the STAMPEDE data, would that be the most important factor?
No yet, because as we discussed yesterday, we don't have Decipher yet for the triplet. So we have for docetaxel alone or ABI alone. But if that demonstrated that we can select patients based on that, of course, because I think we all are very critical with the volumes and the way we select patients based on conventional imaging.
Yes, Fabio.
Yeah, I think that triplet therapy in these patients have to be discussed very carefully with patients because we know that ADT plus RP plus docetaxel is better than ADT plus docetaxel, but we don't know if the triplet therapy is better than ADT plus RP. So I think for older patients or patients with comorbidity, especially who can suffer a lot from adverse events from docetaxel, it's very important to be honest and to say that we haven't no data that adding docetaxel to ADT plus RP have a benefit.
Yeah, I agree, and I think this one is one of the real now the classical questions that you find. So as Elena said, I think most of us at least discuss the option with patients who are de novo, high volume and fit for chemotherapy. But what are we doing with the patients who are chemotherapy fit? Would we give them triplet therapy if they are de novo but low burden? And I guess there are, as always, some patients who are called low burden because also our burden or like chart, that is the chart with actually volume definition, is maybe not perfect, right? Because there are probably some patients who have a lot of disease but don't meet the criteria for high volume. And here is a bit, you see it's very split for selected patients versus not giving it at all. Very few panelists would give it to the majority of patients if they are low burden de novo. If you look at metacronous, low burden, here's a clear consensus not to give triplet therapy, and I think that makes a lot of sense after the meta-analysis that has shown that docetaxel doesn't work in the metacronous. Low burden doesn't give any benefit when it's given alone as addition to ADT, so probably also doesn't work in that population. And then in that more rare situation of metacronous high volume disease, you see here again about a third of the panelists would give it to the majority or recommend it to the majority of patients, and half would say only in selected patients, and only 16% of the panelists would not give it. Even if, because it's a really rare group, subgroup, we don't have a lot of data in all the trials that have tested the triplet therapy. So with that, I think, I don't know if there is someone who wants to comment on that.
I saw at ESMO a slide of a SWOG trial. I couldn't find it on clinical trials, ADT apalutamide plus minus docetaxel. So that would really solve the question of the addition of docetaxel in mHSPC.
Yeah,
Bertrand,
do you know more?
Is it?
I think it's being worked at the cooperative groups. I think
Yes.
Alliance is working on it. So I don't know the status of it, but I know there is active work, and I think they're working on the final details of the design and getting it through the NCI mechanism.
Yeah,
so we'll
because
see.
Michael Morris said 1 year or 2 years ago
there
already.
is a problem. There were two phase 2 with ADT, apalutamide, docetaxel that had to be stopped for excess toxicity because there is strong drug-drug interaction. So that's why in the Titan trial and then the Arches trial, it was sequential docetaxel, meaning you give ADT plus docetaxel and then you give your RPI. So that's really something that has to be discussed. And that's the reason why the EAO guidelines say it's only darolutamide or abiraterone. We have to be careful. Yeah.
Yeah, but I mean, the trial really testing the question, RP doublet with ADT versus adding docetaxel. Michael Morris told me like a year ago, so they're working on it. It is Alliance, when I remember right. As always, it's probably quite difficult to find the funding because no one has probably interest to now test that trial. But I had the impression that they are doing it. And then the design should be easy, right? I don't know if they do it non-inferiority or whatever design, but we hope that we will have the data, and then we could really discuss with our patients with much more enthusiasm, right? If we would really know if that triplet is also better than the hormonal doublets. I agree. Thank you, Petros.
But by that time, we probably use AKT inhibitors, lutetium, PARP inhibitors. So it's probably going to be a completely new field in mHSPC if we can be more specific. We don't know the data. Ursula showed a very nice overview of what's to come. We need to see. And of course, we had a lot of inspirations for the next APCCC if the data are there to get some questions.
Do we have a PR slide, I hope? No?
At the very end.
Oh, wow. See what you all missed here. we chose a lot of them. But yeah, so as you know, no. Now I was too fast. Sorry about that. Oh, no, I think it doesn't go back again. But yeah, so come to 2026, because we're going to discuss hopefully all the new options as well. And in 2025, in February, we have a more diagnostic. We already discussed about that with the colleagues from Romania who said they like to come to APCCC. But still, it will be a very clinical. So it sounds as it's only diagnostics, but it will be very clinical and probably also interesting for people who are like more interested in the localized stage, what we usually don't discuss so much in the main APCCC. So we hope to see you all in Lugano, either in 2025 or in 26 or both. And now I guess we can have all lunch. And if there are more questions, you can ask us. Oh, Bertrand?
Yeah, there is a small conclusion. Yeah. So before you all go out, we would like to thank you for being here. And we have a few messages on top of that. Can we get the last slide? So, first of all, I would like to thank the two organizing committee, both local and international, and especially thank the local organizing committee, Eva, Oksana, Gero, and Ursula, the Vienna team. They did a great job. It was a great meeting, so thank you so much for having us here. We would like to thank the sponsor. You have here the principal gold sponsor. We couldn't do that meeting without the sponsored. That is very important. Finally, you know, Mirror of Medicine is one of the only online UECMA accredited process like this meeting. So if you do to the Mirror of Medicine, and if you're missing some accreditation point, you can go, you can follow, you can have credit. So this is important. If you want your credit, you should go to the website and you're going to have it. And last thing, next, please note that the next prostate, bladder, and renal will be in Portugal, 3 to 6 December 2025. The location was easy to find. The date was extremely difficult to find because there are a lot of concurring meetings, but we finally decided to stick to the same date. We're going to find a local organizing committee, and thank you so much, and have a safe trip home. Thank you.